course, doctor, let me know.
Okay.
Okay, so good morning, everybody. My name is Emmanuele Carballo Rivera. I'm a medical student from Ponce Sciences University in Puerto Rico. And today I'm going to present to you a very interesting case that we have here in Dr. Bernat's office, specifically here in the Alexandria office, where we had a patient that was presenting with Bell's palsy, but when we did some research and we did the past medical history and the history of present illness, we were able to conclude that this patient recently had Wallenberg syndrome. All right, so it's like a left lateral. He had a lesion over there, and we were able to identify that he was experiencing both pathologies at the same time. So that is rare. And Dr. Stein told me to make a case report about it, and given that it was fun, so I think that it was good to show it to you in order for us to enjoy this and learn at the same time. Okay, so what I'm gonna do in the presentation is that I will explain each disease separately, and then at the end I will wish well, Dr. Stein, I eliminated all the identifiers in order to protect the patient's confidentiality, but the story is complete. Everything is in as detailed as possible, always protecting the privacy and the confidentiality of the patient. Okay, so today objectives is to define and explain the etiology of Bell's palsy, to explain the pathophysiologic mechanism of Bell's palsy, to describe the epidemiology, treatment, and management of Bell's palsy, to define and explain the etiology and pathophysiology of Wallenberg syndrome, to describe the epidemiology, treatment, and management of Wallenberg syndrome. And finally, I will do a presentation, a case presentation of the patient that we had in the Alexandria, Virginia office. Okay. So to start, Bell's palsy is a idiopathic facial paralysis in which we have a unilateral paralysis that usually includes the eyes and the mouth. So there's a difference between a peripheral lesion and a central lesion. Usually when you have a central lesion in the cranial nerve number 7, only this area of the face gets affected. But given that it is a peripheral lesion, all right, the patient have both areas affected. I have an example here. There was a patient, his name is Justin Bieber. He has he had Bell's palsy several months ago. And when he tried to smile, he was able only to move the muscles related to the left area of his face. And when he tried to close his eyes, you can appreciate here that the right area of his face, okay, was paralyzed. Nothing was moving in the right area of his face. And that is a classical case of Bell's palsy. But in his case, the etiology is different. He has, I think he has a presentation of shingles, and the virus was located in the cranial nerve number 7, and probably due to a stress-related event or something, it was activated and he developed this paralysis of his face. Now, what about the etiology? In the past, people believe that Bell's palsy occurred due to cold exposure and chilling wind, when you drive in the car with the windows down and it is winter and they're paralyzed their face. They thought that was it, but it's not. Cold exposure was the stressful event, all right, that was causing, in this case, the activation of a virus, all right? In this case, the most common virus that tends to cause Bell's palsy is the herpes simplex virus, all right? This one, usually, if you know from medical school, initially it usually infests the area of the mouth, all right? And then when it remits, it goes to the geniculate ganglion and stay over there in a Latin form, okay? Now, what happened later? When the patient presents or experience any kind of a stress, any kind of stressful event, exposure to cold, exposure to heat, extreme heat, any kind of a stressful event, this virus can reactivate and go to the to a peripheral nerve. And what happened? Like an inflammation is going to develop. All right, the inflammation events are going to develop due to the virus activation, and usually the myelination of the nerve occur. All right, and when the myelination of the nerve occurs, that is when we have the paralysis. Okay, now what happened? Like there's a vital. Like I have to take a home message here. Just put this for you guys. Usually, the Bell's palsy is caused by viral infections, autoimmune reactions to a microvascular disease. Okay, so our patient from the Alexandria office, he has diabetes. So we think that the cause of his paralysis and his Wallenberg syndrome was like occur due to the high diabetes that he has. But I don't want to give you any more details because it's a very interesting case. Now here, I'm showing you guys what I already told you about the geniculate ganglia. So what happens? The patient has an infection, usually located in this area, okay? And the virus get activated during the infection. Some inflammation occur, okay? And then when the virus, like inflammation tends to control the infection. When the inflammation is done and the infection like remits, this virus tends to drive and go to the geniculate ganglion here. And it stays here, okay? It stays here in a latent form, okay? It stays here in latent form. Then what happens? Let's say, like I told you, repetition is key, okay? You have a stress, say like cold exposure, extreme heat exposure, like a special event, like let's say there's something very bad happens and the person has a lot of stress. For some reason, this kind of stressful events activates the virus that's located in the ganglion, all right? And the virus goes to the peripheral nerve, induce again an inflammation. That inflammation induces like a demyelinization process, and that is why we see the paralysis. Some patients recover completely from this, but other patients have like remnant of this illness and inflammation. Okay. If you have any question, you can stop me anytime. Okay. I'm trying to be as clear as possible. Now, what about epidemiology? Usually we have 23 cases per every 100 persons in the United States. And in a worldwide setting, we usually have like 15 to 30 cases for every 100 population people. It's not like, it's kind of common, as you can appreciate. The treatment is usually steroids, okay? But now that we know about that many patients are positive to herpes simplex virus, acyclovir with prednisone is helping the patients to like recover from the illness in a faster way, okay? So what happened, like during the recovery process, this patient can have problems with eating, drinking, like swallowing in a general way. I think I have speech disturbances too, okay? So occupational therapy and speech therapy assessment is recommended, all right? In order to like try to make the patient as functional as possible, okay? That's the most important thing, like to make the patient as functional as possible, because the patient, they have to work, they have a life, they have family, all that. Now, I explained to you guys here that like when the inflammation occurs, a demyelinization process started. Like some people recover completely, some people don't recover at all. And, you know, usually they have cosmetic problems because of the paralysis, you know, like you can appreciate here. Can you imagine close your eyes and having that kind of appearance? So there are three kinds of recovery based on the prognosis of the patient, which is the complete recovery, where the patient recovers everything. The incomplete recovery, like where like we have some fascia motor function that is like we have weakness in the face, like it's just weakness, but like you have to look in the patient like in a very careful way in order to notice it, because is not very apparent, okay? So it's just weakness. And there is the permanent neurologic sequela, which is very, very clinically apparent. Like patient's not gonna be able to move half of his face. Usually these patients tends to recover from 6 weeks to 3 months, okay? Now what happened? Our patient had this presentation, but it was not due to the herpes simplex virus infection. We think it was because of the diabetes mellitus, but I'm gonna explain that to you later. The second presentation that we find during the interview process was the Wallenberg syndrome. So what is Wallenberg syndrome? It's a vertebral artery occlusion or a pica occlusion that induces an ischemic event in the patient, right? So usually the patients initially present with nausea, vertigo, vomiting, because of the involvement of the vestibular system, okay? So like this image here can help you a little bit. And based on the location of the ischemic event, there are some stuff that are gonna be affected, okay? Like here. So the lateral medullary infarct usually occurs in this area of the medulla, okay? Like this. What happens? That given that the lateral medullary zone is affected, we have several neurological tracts that are affected in a significant way, or depending on the size of the lesion. The bigger the lesion, the more the symptoms, the less chances to recover from this illness, okay? But like our patient, he has not like a significantly big illness. He just have like what we call a lacunar infarct. So he was able to recover in 3 to 4 weeks during the treatment that he received in the hospital, okay? Now, so what is Wallenberg syndrome? Like it is a collection of symptoms that the patients tend to develop after an infarct in the pica or in the vertebral artery, all right? So the first thing that is affected is the spinothalamic tract. So what happens? They have a contralateral loss of pain and temperature, okay? Then the spinal trigeminal nucleus is affected, but this one is one of the coronary nerves, as you can remember, all right? And we will find here an ipsilateral facial loss of pain and temperature, okay? The third one is the nucleus ambiguous. The nucleus ambiguous usually supplies the vagus and the glossopharyngeal nerves, and the patient tend to present with dysphagia, dysphonia, diminished gut reflex, and it's very noticeable. Like the most, I think that like the worst symptoms here is the dysphagia, because the patient that we had, he presented with dysphagia, okay? Then the inferior vestibular nucleus is affected. That is why these patients tend to have nystagmus, they tend to have vertigo, and they tend to have nausea and vomiting. Then there are some sympathetic fibers that runs like over here. If the inflammation is very significant, they can affect the sympathetic fibers. And usually these kind of patients, they develop ipsilateral Horner syndrome. And finally, of course, the inferior cerebellar peduncle, okay? So over here, you can appreciate here, this is an MRI image of a lacunar infarct. This is the cerebellum in the inferior area. And the cerebellar peduncles are located like over here. These one are affected too due to the inflammation process, okay, and the ischemic event. And well, patients tend to develop ataxia to this, like because the function of the cerebellum in that area is to maintain volume and organization of movements in the body, okay? So as you can explain, like this is an MRI of the patient. This is not the patient. This is a image that I took from the internet because I'm not allowed to put like documents from the file of the patient like in this setting. But like, oh, I can hear something over here. So, but like we have a lacunar infarct located in this area, the lateral medullary zone, and this is the one that is causing the symptoms of the Wallenberg syndrome, all right? Associated with a lot of events. Like in this case, this was the patient, okay, this is an axial view MRI presenting a soft ischemic change in the, yeah, that is exactly what I said. All right, so this is the reason of why the patient, like I can repeat again, this is the reason of why the patient had ataxia, because usually in the lateral medullary region, we have the cerebellar peduncles very close to them. And that is why these patients tend to develop dysbalance and dysmetria and of course, ataxia again. What is the epidemiology of these kind of patients? So a study of 25 cases, they found like most of the time, Wallenberg syndrome is found in middle-aged men of approximately 55 years old age, in which they present with large artery atherosclerosis, all right? So usually these people, they have large artery atherosclerosis, they have hypertension, they have diabetes, and they smoke, okay? Our patient had a history of hypertension, he had a history of diabetes, and he had a history of smoking too. So he had all literally the risk factors in order to develop this kind of ischemic event, okay? But the only difference with this patient is that instead of being located lesion in a large artery zone, it was a lacunar event. So we assume that given that it was a lacunar event, it was a ramification or a branch of either the pica or the vertebral artery, okay? Now, what we do with patients that develop Wallenberg syndrome. So usually this is a very like a extreme situation. The patient needs to be in a ICU room, and the management usually is TPA, okay? So, but you need to give the PTA within 3 hours in order for it to work, okay? And this is the first thing that we do in the emergency setting, okay? Then we give general medical therapy, like monitoring, we look at the patient, like we give some IV like after the IV thrombolysis, we need to check if the TPA is causing like any kind of bleeding, you know, like any kind of adverse event related to the medication. We need to check on that as soon as possible that we bring the treatment to the patient. Of course, we need to maintain the patient hydrated. That is why we need to give normal saline to the patient. The blood pressure needs to be checked too. We need to have a check on that. And of course, we need to give like a speech therapy assessment in order to verify his ability to communicate and like his ability to ingest food and water, okay? Of course, we need to give the patient deep vein thrombosis prophylaxis because we don't want another ischemic event in this patient, and we can give chronic treatment of antithrombotic to this patient. Now, after the hospitalization, if the patient recovers, it's recommended to give as early as possible physical therapy and occupational therapy, like for the patient to rehabilitate as soon as possible. So here I have explained like the main characteristic of what is Bell's palsy and Wallenberg syndrome, and why I have to explain this once in order for you guys to understand the case. Okay, so now I'm gonna read
the hand in front of the camera. We cannot see. Thank you.
Oh, sorry. Yeah, of course, doctor. So now I will explain to you the case of the patient. I'm gonna read it out. Okay, this happened approximately 2 weeks ago here in the Alexandria office, and it was a patient that he was very stressed about it. Like he was very, very worried about his health. Okay, so I'm gonna start. A middle-aged Latino male from Peru presented to Dr. Bernat Alexandria office, complaining of having a left facial paralysis after watching TV at his home. That started 2 months ago on May 2022. He was not able to either close his mouth nor eye in the left side of his face. He experienced pain sensitivity to cold water and air in the left face, and the symptoms are still present during the office visit. 1 week later, after his Bell's palsy initial event in May 2022, the patient explained that he was diagnosed with a stroke in the left medullary region. After visiting the hospital due to the sudden feeling of walking like a drunk man, this one was the first one. This is the first thing that he said. He was walking like a drunk man suddenly, which is a symptom like this is ataxia. A constant facial pain with loss of ability to feel changes in temperature, hardness. Like, okay, so he already have the Bell's palsy before the stroke, but the difference was that he was not able, okay? He was not able to feel changes in temperature. Like it was numb, all right? He was having now a constant facial pain in the left area of his face, and he presented with hardness, dizziness, blurred vision, and inability to drink or eat solid food. All right, so he developed dysphagia in a significant way. These symptoms persisted for 3 to 4 weeks until they remitted, but the Bell's palsy symptoms were still present. All right, so like during all this time, he experienced like the stroke event. He started with the Bell's palsy symptoms. Then, like 1 week later, he developed a stroke. It was a left medullary lesion, and then the lesion, after receiving treatment in the hospital, like remitted for 3 to 4 weeks, and he developed, like he continued having the Bell's palsy symptoms. During the patient's visit at Dr. Bernat Alexandria office, a detailed history was done, and we analyzed the patient test results from the hospital. And that is when we find a localized lacunar infarction that was identified in the left medullary region, okay? So based on the patient's HPI, past medical history, and test results, we were able to conclude that the patient had a diagnosis of Wallenberg Syndrome with Bell's palsy, both at the same time, okay? And this occurred due to concomitant risk factors that the patient presented, given his history of hypertension, okay, and uncontrolled diabetes mellitus. This patient has an HbA1c of 13. So you can see, like, it was extremely high. Like, it was like a super uncontrolled diabetes. And we think, like Dr. Bernard and I, we think that this is the reason of like his Bell's palsy and the stroke. Why diabetes as a reason of Bell's palsy? Well, because we think like osmotic changes due to high glucose levels probably like induce a demyelinization process in that area, and that is why he has been having the Bell's palsy for such prolonged period of time. Okay. So Dr. Stein, ladies and gentlemen, this is all my presentation. I hope you enjoy it, and I wish you a nice day. Okay.
Thank you.
Of course.